Thank you. I'm Dr. Sujeewa Weerasinghe, a consultant clinical oncologist from National Cancer Institute, Sri Lanka. So we are going to talk about hospital-based palliative care models today. About hospital-based palliative care, we deliver palliative care into two categories: hospital-based palliative care and the home-based palliative care, or the community-based palliative care. Today, we will look at what is hospital-based palliative care models and what type of units we can start in our hospitals. It could be, there are three models. One is outpatient clinic. Number two is palliative care consult service as an outpatient or along with the outpatient clinic. And also, you can start as a palliative care inpatient unit, which is devoted only to palliative care. So, and I hope you can understand, just like oncology unit or any other cardiology unit or any endocrinology unit ward. So you can start a unit along with beds as a palliative care unit in a hospital. We will look at very briefly, we will look at what these things are for and the advantages and disadvantages of having them. If you all think critically, number one is we all have to think critically. When somebody wants to start a palliative care unit, actually, you have to think critically initially. So get together, whoever, a small group who is willing to start palliative care in your hospital, you all get together and think about what resources do we have, what resources can be obtained, and do we have manpower, do we have funding, and how cost-effective our unit is, and the sustainability of our unit, which is the most important thing, the sustainability of the unit. Our outpatient unit, as you know, it is very easy. You just have an outpatient clinic once weekly or few days a week. You can start as an outpatient clinic, but as you know, the patients seeing and then they are going out, and this model very difficult to provide proper palliative care. So, but my advice is, if you are starting outpatient clinic, start outpatient clinic with intention to improve it up to the next level at least. The palliative care consult service. If you look at the palliative care consult service model, that also has two separate levels. It could be recommendation only or actually assuming the care of the patient. So this is palliative care consult service model is something in between outpatient clinic and the inpatient unit. Okay. So whether you have to decide whether you are getting recommendation only clinic, that is, you see the patient as outpatient, and inpatient referrals, you go to the wards and you give your recommendation, talk to the patient, take histories, examination, plan of management, you give your recommendation and come back. So this model will not be able to make a very good impact on patients. We will see the next model is the actually assuming care. when somebody is referring patient to you, you need to do daily ward rounds on that for that patient. You need to follow that patient up in your clinic, and you have to take calls from that patient. That is the actual better model as a palliative care consult service. This has to be your aim if you are planning to start a palliative care consult service. That means you have an outpatient clinic, you are seeing inpatient referrals, you are not just seeing and stopping there. You need to follow those patients up while they are admitted in their wards, and you have to get those patients followed up in your clinic as and when necessary and regularly, and you need to take calls from that patient if he has a problem in any palliative issue. So, how a palliative care consult service functions? So actually now we already talked about it. You take outpatients and inpatient referrals on daily basis. You do daily ward rounds on the patients referred to you, and take patient calls, preferably 24 hours. Preferably, you have to take 24 hours patients calls. You need to have an open hotline, and you need to liaise with the treating unit and the treating consultant. You just can't handle the patient alone. The patients are not referred to your clinic, your unit totally, while the patient owner is the treating consultant and the treating unit. You are doing a consultation, but you are following up the patient as well. And you need to liaise with them, and you need to liaise with the local or the peripheral health facility of the patient's closest peripheral health facility as well. That is called shared care. The patient, imagine if the patient from somewhere far away coming to Maharagama, say that a patient from Gampaha area coming to Maharagama, so you need to communicate with the Gampaha hospital. If there is a palliative care unit, you communicate with them. If there's an oncology unit, you communicate with them if it is a cancer patient. So that is called shared care. There's much more about shared care, but in very short, that is shared care. Then you have to do awareness and training of your hospital staff and the patients, caregivers, and everybody. And there's another obligation. If you are doing a palliative care consult service, you need a very good data collection, statistics, and you need to do research as well using these statistics. So if the next is the inpatient palliative care unit, if you have an inpatient palliative care unit, there's an advantage because there's ability to create an environment conducive to supporting patients and families. So this environment is more receptive to the support patients and families. It's very easy for you all to work if you have a separate place rather than you are working in somebody else's wards. And also your donors would like it. So your donors would like to see your unit, your wards, your beds. And because when they spend money on donation, they have space to see. And donation of hardware is more concrete than donation of salaries and running costs, actually. So the donors would like to donate hardware more than the running cost and the patient benefits and all that. So that would be more, inpatient unit may be more attractive to donors because there's a place to see. Inpatient palliative care unit, but there are some constraints with that. to develop an inpatient unit, it is much more expensive to run and develop, much more expensive. At the same time, expensive to run and sustain. If run by a charity, you need to have very strict admission and discharge criteria. Also, if you have a hospital inpatient bed unit as a palliative care unit, there's a small risk of dumping of patients. Others don't want to look after, so that problem is also will come. Advantages of setting up palliative care consult service over inpatient unit. Compared to inpatient unit setup, palliative care consult service PCCS is easier to set up because less space, less space is needed, less funds are needed to start the PCCS. It is easier to set up. And you don't need to fight for beds with other consultants in the hospital. And it becomes a service to your colleagues, not just patients and the families. Because when there's a patient who need a lot of symptom care, a lot of social, psychological issues, the patient's primary unit and the consultant have to spend a lot of time on those settling those problems. If you go forward to settle those problems, it will be a service to your colleague consultant or it will be a service to your colleague consultant. So, and a benefit to the patient as well, so that they will like it to have you as their partner in managing patient. And we are not stealing other people's patients. So we're not taking care of total care of the patient. We are just doing a active management and consultancy. We are not taking over patients. And however, whatever said and done, you need to remember, we go to other people's ward and see the patient. You have to be very diplomatic. You have to be very diplomatic, should not fight with anyone, and you have to have a very good tolerance capacity to do this. Other considerations, further considerations in this, are about statistics. Very important to measure what we do. Why do it is important to measure? We need health statistics for administration and for our donors also. We have to show that we are treating this much of patients, and so the statistics, our statistics, the donors would like to see. And also we, for ourselves, we also like to see how much work we have done. And for our patients also, we can show that we have seen this much of patients, so that these statistics are important not only for the administration and the health statistics, but for others as well. I will stress you that data collection has to be start very simple manner. We can list the patients referred. We can have a list of patients looked after, and how many patients per month or year, and how many visits per month and year, and this patient is referred by whom, or how many telephone calls to patients, and how many telephone calls to family members or colleagues. Those things we have to record for our statistics. As you know, when you start a palliative care unit, the National Cancer Control Program is there's a process that they need the return of statistics. We have to send statistics from each unit, who is either you do a OPD or a PCCS. We need to send our statistics to National Cancer Control Program. They are doing a very systematic statistic data collection procedure. We need to comply for that. Very important. And you should take as data collection is key. It should not be used. Data collection should be used as a friend, not just as a stick. So you be friendly with the data collection. Some tips. Start with your, these tips are for when you are going to start a palliative care consult service. Since we have started our unit in 2015 and we are still having a sustainable clinic, we are trying to progress further, and we have some tips for you if you are starting clinic, PCCS. First, I will say that you start with your own patients and few referrals from other consultants who are very keen to do palliative, very keen. Don't try to push who are not very keen. So later on, they will also comply. So try first with the consultants or units who are keen to send their patients to the palliative care unit. You have to do whatever you can out of all the available palliative models, either clinic or consult service or inpatient unit. So the clinic or start as a clinic and then develop into a consult service, or start with a consult service is the recommended, rather than all of a sudden starting inpatient unit without having a palliative care dedicated consultants. It may be, so that's what I feel, but it may be different. If you still can manage, you can start an inpatient unit, but according to what is recommendation is consult service. Start with the consult service. And also, you have to be happy what you managed to achieve. Do not regret what you cannot do. So you have to first do what you can. You cannot, you should not regret that I couldn't do this, I couldn't do that, I couldn't do. So there are things, there's a limit we can do, there's a limit we cannot do. So we need to identify that, and you should not regret if you couldn't do. You try to achieve that target in a future patient. Maybe for the future patient, you can try to achieve that target, which you couldn't do with the previous patient. Acknowledge positive comments and ignore negative comments. When you go to wards and wards doing ward rounds, so there will be lots of positive comments as well as loads of similar negative comments. Initially, you will get more negative comments than the positive comments. So you should learn to acknowledge the positive comments as well as ignore the negative comments. Never create conflicts with other staff. Always have good things to say to your colleagues, especially to their patients. So you need to commend their other units, management and their care to the patient. But do not try to criticize or create conflicts. Even anybody try to create conflicts, you can be quiet and, be quiet. That's the main advice we need to give. Always look into sustainability. A slow journey is more sustainable. A slow journey is more sustainable rather than starting big. It will not be sustainable, but if you start small and slowly develop, it will be more sustainable. That's the general principle. It is very important. It is good to start with good intentions. If you are starting something with good intention, definitely you will achieve it. A dedicated group of people has to be there to do this. Integrating palliative care unit into practice. A good clinician treat the disease, but the great clinician treat the patient who has the disease. We know that the great clinician treat the patient who has the disease, the whole patient, the holistic care. So we need to try to approach this. And there's a saying, a small group of committed individual can change the world. A small group of committed individuals can change the world. Please be that small group. I know the Ministry of Health is will back you. So already Ministry of Health has sent the circular that each hospital should start a palliative care consult service. It is a must. That order is already on. I hope National Cancer Control Program will circulate the letters to you all. So be that small group who is going to change the world. Thank you.